Thank you very much. It's indeed a pleasure to be here. When I first got here, I thought I was going to speak between you guys and dinner. Now I find out I'm speaking between you guys and the bar. So we'll move this forward. I should also tell you that anything that Harlan Pinto or Mike Kelly say about me as a resident or a fellow, they're purely stories. They are not to be believed, and the statute of limitations has expired. I am actually very comfortable talking to a bunch of VA docs. My mom and dad actually met 60 years ago at the Allen Park VA when they worked there. She in the cafeteria and he in materials management. I trained at a VA, and as you just said, I'm a vet, so I'm really comfortable talking to you guys, and it's wonderful to be here tonight. I'm going to be mindful of the time, and I am going to move a little fast. I'm going to show you some data, but sit back, enjoy your wine or enjoy your drink, and don't follow the numbers too much. Just look at some of the trends. I just want you to see my disclosures here. Most importantly, I do a lot of stuff with the federal government and with Turner Broadcasting. I have a book that I published about a year and a half ago that hit the New York Times bestsellers list for a time, but the talk is not really about that today. We're going to talk about the health economy, talk about some of the trends in cancer, talk about that whole movement to redefine cancer, and then talk about cancer control, and we're going to try to do it in about 20 minutes. So forgive me if I do what those of us in the South don't normally do and speak very fast. By the way, Sean, you mentioned Pinot Noir. When you go to the bar tonight, since you're in Georgia, you're going to want to ask for a Pinot Noir. Now, in 2010, we in the United States spent $2.6 trillion on health care. Now, $2.6 trillion is a lot of money. A million seconds ago was Saturday of last week. A billion seconds ago was about the time Richard Nixon resigned. Given this week, that was a much better time in American government. A trillion seconds ago was 30,000 years before the Christian era, 30,000 BC. So a trillion is a big number, and we spent 2.6 of them on healthcare in 2010. We spent $1.1 trillion on food when we spent $2.6 trillion on healthcare. For every dollar spent in the United States in 2010, 17.9 cents was spent on healthcare. If the healthcare economy in the United States were its own country, we would be the 6th largest economy in the world. We spent more money on healthcare in 2010 than was spent on everything bought in France. Okay, we are big. That 17.9% of the economy is growing. And those people who think that we don't need healthcare reform, I got news for them. We will have healthcare reform, because if the last 20 years tell us what the next 20 years are like, by 2030 we will be spending 30 cents out of every dollar on healthcare, and the economy simply cannot sustain that rise, and the economy will collapse. When we look at other countries, I heard a congressman from Georgia talking about how great our healthcare system is. When we look at outcomes from healthcare, we don't do well in infant mortality. Indeed, Cuba does better than the United States in infant mortality. When we look at white male life expectancy, I chose 2 other countries, Canada because we love to bash Canada, and then Switzerland. They do better than us in infant mortality, they do better than us in life expectancy, they do better than us in white male life expectancy, and their per person costs for health care are a lot less than in the United States. In the case of Canada, about half that in the United States. By the way, Canada is 10th in life expectancy among United Nations countries, Switzerland is 4th, and the United States is 49th. We can be proud of being 49th. We beat out Romania. They were 50th, by the way. In terms of proportion of GDP, Switzerland and Canada are the second highest GDPs for health care in the world, the United States, of course, being 4. The average among Western European countries is 8 to 9%. This at a time when more than 25,000 people die annually because of lack of health care. That's the statistic I never hear people talking about. And more than 75,000 Americans die annually due to poor quality health care, and thousands suffer because of the inability of pain control and other things. We live in a world where some of us overconsume resources and we're actually harmed by that, and some of us underconsume resources, and that's the cause of many of the disparities that we talk about. And healthcare outcomes could be better, meaning people don't have to die needlessly if we simply started following the science in our practice. We often use treatments and interventions that are lucrative to providers but not proven effective. We often fail to do things that are very simple and inexpensive and proven to be effective. So this is a call for evidence-based medicine. The politicians try to scare us with rationing of medicine. We need to start talking about the rational use of medicine. And there are numerous examples of how we overuse medicine or abuse medicine. I'm thinking of the drug, I'm sorry if they're a sponsor of yours, Nexium. Nexium at $6 a pill is on the market because the AstraZeneca presented 2 studies to the FDA showing that it was equivalent to Prilosec, another AstraZeneca drug that was becoming generic. The active ingredient in Prilosec is the active ingredient in Nexium. The European Union refused to give Nexium a patent. The US government did. Nexium is one of the 10th most prescribed drugs in the United States today at $6 a pill. Keep in mind it is on the market because it is proven equivalent to generic Prilosec, which is now available at 20 cents a pill. Okay, the 10th most prescribed drug in the United States is on the market because it has been proven to be the same thing as something 1/30th of its cost. This is an example of waste in the United States. It didn't happen in Europe. Now let's look at the National Cancer Act. Richard Nixon is in my talk a lot tonight because of the government shutdown. Little bit more than 42 years ago, he signed the National Cancer Act, giving a lot of money to science. And all of a sudden, from that, we can ask, what did we get? We got a better understanding of what is cancer, what goes wrong in the cell, and what makes it cancerous. We know what causes the cancer problem, which helps us with prevention. And this has translated into some lives being saved. Just sit back, don't pay too much attention to the numbers. In 1900, for every 100,000 Americans, 64 died of cancer. In 1970, for every 100,000 Americans, 163. This is the rise in the mortality rate from cancer. It continued until 1991 when it peaked at 215, and since 1991 we've had a 20% decline in the mortality rate from cancer. We're down to 170. I should note, while we paid for all of these advances in oncology, the United States was the 31st country to have a 20% decline in cancer mortality. Now, when we look at that cancer mortality, these are just slides from 1990 to 2010. The decline in blue is men, the decline in red is women. You can see men had a decline greater than women. When we look at the races and ethnicities as defined by the Office of Management and Budget in 2010, you can note that everyone had a decline in mortality except Native Americans and Alaskan Natives in green. By the way, I specifically note that this is the OMB definition in 2010 because many people don't realize that race is a political categorization and not a biological categorization, and it changes over time. The Office of Management and Budget defines race 2 years before every census. So in 2008, they gave us the 2010 definition. In 1998, they gave us the 2000 definition. And I say this because many people don't realize that in 1970, Barack Obama was a white boy. In the 1970 definition is you are the race that your mother considers herself to be. If you know someone who's Indian, who lived in the United States since 1950, they've been 3 different races in their lifetime. They were actually Caucasian in 1960. Now, when we look at mortality rates, lung cancer has declined by about 20% over the last 20 years, breast cancer by about 34%, colon cancer about 39%. In the case of breast cancer, this means that a woman who's 50 to 60 years old today has about 2/3 the risk of dying from breast cancer as a woman who was 50 to 60 years of age about 1990. So this is actually still some progress. Looking at lung cancer, these are death rates from lung cancer. You can see in 1975 we were on the upswing for men in blue, women in red, and we started coming down a lot faster for men than for women. This is, by the way, the 50th anniversary of Luther Terry's announcement, the Surgeon General's announcement in 1964. It was January 14th, 1964. The 50th announcement will be this January. The decline in smoking has been precipitous since that announcement was made. Many people do not realize that 55% of adult men smoked in 1964. 35% of adult women smoked in 1964, and we're down about 20% or so. We'll show those numbers in just a second. Looking at 2010 race ethnicity definitions, you can see the percentage of smoking among Native Americans. It's about 1/3 of Native Americans smoke, be they male or female. Among Asian Pacific Islanders, it's very low among women. Note, it's about 22% of men, about 16.5% of women. I don't know what it is among veterans. That's still a problem. It was when I trained, and I know it still is today. Among people who are poor, it's about 30% who smoke. Lung cancer screening is all the buzz. I don't have a lot of time to go into lung cancer screening, but I will tell you that the lung cancer screening trial that was done by the National Cancer Institute was one of the best trials ever done, and it showed the double-edged sword of screening, the good and the bad of screening. It actually showed a 20% decline in death among people over 55 who were heavy smokers. By the way, there's a hospital here in Atlanta that has used that data to say there's now a trial to show that screening for lung cancer saves lives, and instead of trying to enroll people over 55 who have a 30-pack year greater history of smoking, they are actually encouraging women in their 40s who've lived in an urban area for more than 10 years who do not smoke to come pay them $300 to get spiral CT screening for lung cancer. That's an example of how we end up with this $2.6 trillion. That's a waste of resources. But in any event, the lung cancer screening trial actually showed a 20% decline in risk of death. It's important to remember 80% of the people who were going to die still died. It's also important to remember that that 20% decline translates into 5.4 lives saved for every 1 life lost due to medical interventions caused by the screening. Actually, 1/3 of the people who died because they were in the screening trial on autopsy did not have lung cancer. So screening can be harmful and screening can be helpful. To a professional screener, lung cancer screening, it's 5.4 to 1. And many of us at the National Cancer Institute, at the American Cancer Society, the American Society for Clinical Oncology, a number of other organizations actually now recommend informed decision-making for lung cancer screening. You're going to hear about informed decision-making a lot when it comes to screening. Breast cancer. Here's that 34% decline in breast cancer. Going down to the right is good, especially if you've had a couple of glasses of wine. 34% decline. For black and white women, you see black women in blue, white women in red. And you're going to hear a theme from me here. The death rate for blacks and whites was the same in the 1970s, and the disparity between blacks and whites only started in 1981, and it has continued every year since. And it was worse in 2010 than it was in any time in our history before. This is because we started learning how to treat breast cancer in the late 70s and early 80s, and this represents the 20% of white women who don't get adequate care and the 35% of black women who don't get adequate care. Keep in mind a substantial proportion of white women get less than adequate care as well. Now, many people think mammography is the reason for this 34% decline. They are wrong to a certain extent. The number one reason is improvements in treatment. The number two reason is awareness of the disease. The power of a woman getting dressed or taking a shower and saying, "What the hell is this?" and going to a doctor to get it figured out is amazing. And it is the number two reason why there is a decline in mortality for breast cancer. Keep in mind, when Mrs. Rockefeller and Mrs. Ford announced that they had breast cancer in 1976, it wasn't even sociable to say the word breast cancer on television. Screening with mammography and clinical breast exam is the third reason why there's a decline in mortality. One of the things that I worry about from my job is we so overstress mammography and so understress the other two reasons for the decline, the two reasons that are actually more important. I should point out, while the number one reason for the decline is improvements in treatment, you're sitting in a city here in Atlanta where not too long ago, we did a study and showed that 7.5% of black women and 2% of white women diagnosed with a curable early-stage breast cancer got no treatment within the first year of diagnosis. We're not talking about less than optimal treatment or less than adequate treatment. We're talking about no treatment within the first year after diagnosis. They had enough access to be diagnosed, to get a biopsy and have a pathologist read it, but they did not get treatment for whatever reason. And so finding optimal treatment for people is an important point, especially since it's the number one reason for the decline in mortality. Colorectal cancer, again, going to the right and going downward is important. Here we have men in blue, women in red. On this slide, the two top lines are men, the two bottom lines are women. Black men in blue, white men in red, black women in green, white women in purple. Again, in the 1970s, there were no racial disparities, and all the racial disparities started in the early 1980s. And this, too, is an example of what happens when one group of people are more likely to not get adequate treatment than another. Please keep in mind a goodly number of whites get less than adequate treatment as well. The decline here is due to improvements in treatment as well as screening. Indeed, there's a lot of emphasis on colonoscopy in this world. The reason for the emphasis in colonoscopy, quite honestly, is you can charge $3,000 for it in the private sector. The clinical studies to support stool blood testing are actually stronger than the clinical studies to support colonoscopy, but stool blood testing costs $30 a year. Awareness of symptoms is also important. Most organizations recommend screening, and they recommend that people get any test. Colonoscopy works, sigmoidoscopy works, stool, barium enema, if you can find somebody who can still do it, even works. Stool blood testing works in a prospective randomized trial. Indeed, the greatest problem in colon cancer is nearly half, 40 to 45% of all people over the age of 50 have never gotten screened. We live in a world where we could actually prevent 15 to 20,000 deaths per year if we just logistically got $30 a year stool blood testing to everybody over the age of 50. Again, I'm not against colonoscopy screening. I just want people over the age of 50 to get something. And it's a logistical problem to get them stool blood testing. This is for the folks who are against healthcare reform. This is probably the most complicated slide I'm going to show you tonight. It's also, I think, as an American, the most distressing slide. This is Kaplan-Meier plot, and red is stage 1, blue is stage 2, green is stage 3, yellow is stage 4. The dotted lines are uninsured, the solid lines are insured. I just want to show you 5-year survival, or 60 months on the x-axis, with 0.5 being 50%, 0.7 being 70%. Go to the upper right over here. Do I have a, yeah, I have this here. I just want to show you that stage 2 insured has a better 5-year survival rate than stage 1 uninsured. In the United States of America, you're better off having the more advanced colorectal cancer with insurance than the less advanced colorectal cancer without insurance. You are more likely to be alive at 5 years with stage 2 colorectal cancer with insurance than stage 1 colorectal cancer without insurance. And insurance does matter. You'll note at no stage, even at stage 4, the dotted lines are not on top of the solid lines. They're always under the solid line. So insured people at every stage are less likely to survive. Prostate cancer. Used to say what a mess, although it's gotten a lot better recently because people are actually starting to come around to agreement, and they're starting to come around to my side and the side that I've been advocating for 20 years. You see, the benefits of screening and aggressive treatment of localized disease are still questionable and not known. Many of these big screening fairs that people had, the only scientific evidence of benefit we had were to the doctors and the hospitals and the clinics that offered those screening things. The harms of prostate cancer screening are actually better proven than the benefits. We simply don't know if it saves lives. Many organizations believe that men need to be informed of the controversies, both the known and the unknown, and allowed to make decisions that they feel comfortable with. That's not a statement against screening. That's a statement for men knowing the pros and cons and them making the educated guess about what's right for them. Recommending for such informed decision-making are these 6 organizations. You can see My American Cancer Society is at the top. Many people don't realize that the American Urology Association also recommends for informed decision-making. Recommending against routine screening are these 3 organizations. The Preventive Services Task Force has gotten quite a bit of publicity recently about that. The American College of Physicians' statement on their website is that men between the ages of 50 and 69 should discuss, and the emphasis is theirs, the limited benefits and substantial harms of PSA testing with their doctor before undergoing screening for prostate cancer. Many people, indeed many urologists, don't realize this is what the urology community is now saying. The American Urological Association literally says, given the uncertainty that PSA testing results in more benefit than harm, a thoughtful and broad approach is needed. It is critical, and the people need to be informed. This is simply not happening in a lot of places. In May of 2013, they recommended screening for men aged 55 to 70 who are in good health, but that those men should be informed of the harms and benefits of screening. Again, the importance of those of us in healthcare, both understanding the science and the importance of clearly explaining the science. I should note that papers like this, there have been about a dozen papers with similar titles in the literature within the last 2 years. We're trying to figure out if Gleason 6 prostate cancer should be called cancer. An alternative title to this is how do we tell the 48% of men we treated over the last 50 years for Gleason 6 cancer that a bunch of us are wondering if you really actually had cancer. Literally 48% of men treated for prostate cancer over the last 50 years. A bunch of us are wondering if they actually had cancer. And that brings us to redefining cancer and this guy, Virchow. Those of us who are nurses and doctors will know Virchow from Virchow's node. He also defined the conditions that cause thrombosis. He called himself a cellular pathologist and one of the first people to do that. He actually defined cancer as uncontrolled cell growth. He's the first person to define to find a patient and label that patient a leukemia patient. And he made the definitions that we currently use, or the profiles that we currently use of cancer, by doing a series of autopsies, doing fine biopsies. He was the first person to do H&E staining. He looked at a light microscope in 1848 with a candle, and he drew pictures. And he would look at something like this, and he could draw, this is an adenocarcinoma of the lung, and he could draw pictures, and he created, and he published in a book, which if any of you ever go to the Mayo Clinic, there's an original copy of his book at the Mayo Clinic Library under glass, but you can still see it there. He's the guy who defined what cancer was. Now, he did it on people who died. Nowadays, keep in mind, the X-ray was 1895, 50 years after Virchow was working. Mammography is the 1960s. CT scanning in the 80s. Ultrasound in the 60s and 70s. MRI in the 80s. Some of the stereotactic biopsy stuff that we do nowadays was patented this century. Literally, there is a woman in a hospital near here who yesterday had a biopsy of a 5-millimeter lesion in her breast that was seen on mammogram and MRI. It went off to a pathologist. The pathologist is processing it right now and going to do an H&E stain on it and going to look at it Monday morning. And that pathologist is going to say this 5-millimeter lesion looks just like what Virchow called breast cancer in 1848. 165 years ago, Virchow said, this is what breast cancer looks like. Now, that woman is going to be told that she has breast cancer and she's going to be treated. Now, when we look at all those curves that I showed you and spend a lot of time analyzing them, we can actually tell you that about 20% of radiologically detected lung cancers, about a quarter of the mammographically detected breast cancers, 40% of the ultrasound detected thyroid cancers, and over half, close to 60% of the prostate cancers that we find that are localized. Those people have something that looks like cancer, but it is not genomically programmed to grow, spread, and kill them. It is genomically programmed to stay in the original organ and never bother them. In the case of prostate cancer, where we kill 1 out of every 200 guys we do a radical prostatectomy on, it's likely that we're killing, and 120 of those 200 don't need treatment. It's likely we occasionally kill somebody who never had a cancer that was going to kill them unless we had screened for it and treated it. And also, we have about 14 million cancer survivors today, about a quarter to a third of whom have had what's called overdiagnosis. I hate the word overdiagnosis, but that's what the epidemiologists have given us as the name. What we desperately need is a 21st century definition of cancer. And we need to realize that we've been dealing with a mid-19th century light microscopic definition of cancer for the last 160 years. As our technologies have advanced and we can find all these localized diseases, we desperately need a 21st century definition of cancer. This will spare those who do not need treatment, and redefining cancer is an active area of research. Genomic analyses, looking at what genes are turned on, what genes are turned off, and looking at patterns, the profile. And by the way, Virchow actually used the word profile when he talked about cancer. This is the profile of cancer. And actually, one of my fellows recently told me that the metaphor that I should be using, maybe I'll use it with you guys, but I won't normally use it, is, you guys ever hear of racial profiling? This is pathologic profiling. It looks like something that killed, therefore we assume it's going to kill. Okay, but anyway, genomic analyses, things like Oncotype DX, MammaPrint, may actually help us in breast cancer. We now have Oncotype DX for colon cancer as well as for prostate cancer. But that's really the future. Now I'm going to sum up by last thing, look at the causes of cancer. I want you to note, this is Graham Coldit's paper on the causes of cancer. Number 1 cause is smoking. The number 2 cause, many people don't realize, a triad: obesity, poor nutrition, and physical inactivity. It's a three-legged stool. It's not just obesity. It is poor nutrition and physical inactivity as well. It's the second leading cause of cancer. Many people don't realize it causes at least 12 different cancers. This is actually knowledge that's been gained from epidemiology just over the last 25 years. In the 1970s, we didn't realize how important obesity was in the cause of cancer. Now, we know about smoking, and we know that smoking rates have gone down. But unfortunately for adults, in 1970, 15% were obese. In 2008, it's 35%. And more importantly for kids, 4% were obese in 1970, and 20% are obese in 2008. Dramatic rise in obesity. And by the way, I'm talking about the condition known as obesity. Conflict of interest rules do not allow me to talk about the condition known as overweight. Now, if you look at, and these are not OMB categorizations for race, but these are categorizations of race and ethnicity from another group. You'll note half of all black women are now obese. 43% of Hispanic women are obese. This is a real serious problem. That's obesity. That is not overweight. That's obesity. If you add overweight, you get over 70, 80% in some of those categories. Now, what we're having is a tsunami of chronic disease caused by obesity, physical activity, and high caloric intake. Increasing rates of diabetes, cardiovascular disease, orthopedic disease, increasing rates of cancer. Indeed, that triad I told you about is likely to surpass tobacco as the leading cause of cancer within the next decade. It's already the leading cause of cardiac death. My last three slides. We desperately need to think about the rational use of healthcare. It's actually necessary for the future of the United States. We're going to collapse our economy without it. It's possible to decrease costs and improve healthcare by using science to guide our policies. And we need to think of the number of people whose lives we could positively affect if we simply started getting scientific. We need to respect the science and educate people. We need to intensify our tobacco control efforts. We need to encourage good nutrition and physical activity. It's been a long night. You've been a wonderful audience, and I really appreciate your attention. Thank you.